All right, welcome everybody to our fourth event of the EIM Research Learning Collaborative, or the EIM RLC. And today our topic is implementing the PAVS in your health system, a panel discussion. So just a few slides on my part to begin. We always want to go back to what our goal is with the EIM RLC. And really what we're seeking to do is bring together peers, all of us, to learn, share, and apply best practices from the academic research community, combined with the wisdom of frontline service community providers, to increase the capacity and connectivity of scientists and expand the evidence base for making physical activity assessment and promotion a standard in clinical care. We're doing this through presentations, potentially manuscript reviews, panels like today, mentoring activities we did last month, and maybe as we move along, even some grant review writing workshops. So overall, I want to realign us to our true north with exercise as medicine. Our vision with exercise as medicine is to make physical activity assessment and promotion a standard in clinical care, connecting healthcare with evidence-based physical activity resources for people everywhere of all abilities. And to make this happen, we have to have the evidence, and we have to establish that this what we're proposing is cost-effective and it's effective in improving health outcomes, hence the need for the EIM RLC. So just going back to our core kind of components of exercise as medicine in the healthcare setting, which is what we're really talking about today. We have routine physical activity assessment and screening to get that conversation started. We would like to see that followed up with brief advice, counseling, and our physical activity prescription. And then finally, a referral out to patient physical activity resources. So in these early days of the EIM RLC, we've been focusing a little bit more on routine physical activity assessment and screening. How do we integrate this into our electronic health records? And what type of evaluation opportunities do we have coming out of that? So in October 2020, we had an initial webinar on PAVS 101, assessing patient physical activity levels, where we had two pioneers in the field, Dr. Liz Joy and Dr. Trevor Ball, both from Intermountain Health at that time, present on how they really got the PAVS in their health system, and really the pioneers in the field. And they really, this work really is spurred on work from around the country and around the world. And if you missed that webinar, it's on our webpage. Go there, find it, and I encourage you to watch it. It was a great session. So I thought, why not build upon this today? And really some disciples of Dr. Joy are doing the same work now in their health systems. And I thought, well, wouldn't it be wonderful if we got them together and really heard about their efforts to implement PAVS in their health system. So today we're honored to have Dr. Carrie Dene from the University of Michigan Medical School, Dr. Casey Onks from Penn State Health, and Dr. Cindy Lin from the West Coast at the University of Washington Medical Center. Our plan for today is each of them will present 5 to 7 minutes on what they're doing with PAVS in their health system. Then we hope to spend the last 30 minutes taking questions from the audience and really just having a panel discussion, truly dedicating 30 minutes to doing this. I prefer everyone, if you can put questions in the chat room. In previous sessions, we have conversations going on, we have questions, I'll moderate that, and we'll go from there. So let's go in order from left to right. We'll go Dr. Dene, Dr. Onks, and then Dr. Lin. So I'm gonna stop sharing my screen here and allow Dr. Dene to share hers and her initial presentation.
Just pulling it up here. First of all, thank you all for, oops, I'm sharing the wrong thing. Let me fix this. Give me 1 second. Like Casey said, we do this a million times a day, and of course I just set it up and now it doesn't want to work. Mark, I'm really sorry. Maybe Casey Or Cindy could go and I'll work on this. I literally have no idea what just happened.
No problem. Casey, why don't you?
I'll go. Yeah, let me see if I can
Sorry,
try.
Casey.
You're good.
It's there. Hmm.
Okay, we got that.
Yours looks good.
We good? So our adventure to implementation of PAVS started with an idea for a consultation clinic. We didn't set out just to do vital sign. The actual conversation was surrounding having a place to send patients for consultation of physical activity. So that's where our idea started. And it started at the time of our fellowship. We created a sports medicine fellowship here in 2014. At that time, the idea was that we wanted to make this part of our curriculum and teach our fellows how to go about prescribing exercise. And at that time, we didn't have any leverage to move it forward. And we didn't try that hard because we knew we were going to get hit by some dead ends. But 2018, one of my partners was accepted into a development program, faculty development program. And part of that program was to do a project. And so her project was going to be surrounding exercise as medicine. And about that time in 2018, Dr. Katie Schmitz joined Penn State College of Medicine as a former ACSM president. She was assigned as a mentor for Dr. Butts to help her with her exercise as medicine project. And ultimately, they decided to go for PAVS implementation. And ultimately, Dr. Joy also got in the mix with helping us move that forward, as Dr. Joy uses the same electronic medical record as we do here at Penn State Health. So she'd already gone through, again, as you mentioned, Mark, she has already done this, and she had the same EMR and challenges that we did. And ultimately, in 2020, we went live and took us about 18 months from the time that we actually implemented the plan. So what happened during that 18 months? The champion was identified, and if you look at the website and read about this, everyone talks about you got to have a champion. And surrounding that champion, we had great mentorship and a great team. You can't do this alone, especially in a large health system. Once we developed that team, we developed an approach, and it started with our division in primary care sports medicine, who clearly, as people who advocate for exercise, were fully supportive, and multiple members of our team were part of the overall team, including myself. From a departmental level, that's where we went next. And so we did have to get buy-in from our department, but the vice president of operations for our department happens to be a primary care sports doc. So that buy-in was pretty easy from a departmental level, although we did have to convince our chair that this is something that we should be doing. And our chair, he came from Michigan, to Penn State, so I won't hold that against him, Carrie. But we did have to convince him a little bit that we should do this. Once we got that go ahead, it was off to the health system, and that's where the challenge is. I think honestly for us. Fortunately, again in 2014, when we wanted to do this, we had nobody at each of these levels to really help us move it forward. Fast forward to 2019, the associate CMO is a primary care sports doc for our health system, and the director of ambulatory care for the whole health system is also a primary care sports doc, which those guys were not in those positions 4 or 5 years ago. Them knowing the system was critical, and is why we were able to get through in 18 months. It would have never happened that quickly if we didn't have the knowledge base about health systems and how it works and how to proceed with regards to getting something to move forward, an agenda item. We strategically pulled in the director of quality for Penn State Health, who her whole job is to make sure that we are delivering quality healthcare. And clearly this is something that is very important for quality and likely will be a quality metric in the future for health systems. And she helped us to frame the conversation to leadership. the group of these leaders helped us to get in the room. So it's all about getting in the room with the right people, with the right message. And we eventually were able to get into a leadership meeting with associate CMOs and the chief medical officer to pitch the idea, who did give us permission to move forward with the implementation. That was just the start though. To get the go ahead was huge, but then you have to work with other people within the health system to make sure that it gets implemented into the EMR. There was multiple different legs of our EMR team that we had to discuss with. Where do you put it? What are the questions you're going to ask? How do you word it? And that took many months, actually, once we finally got the go-ahead. So the initial rollout involved training meetings. We went to all the piloting sites and we presented a Q&A session while we're doing this. Here's what it's going to look like. We rolled it out to those sites at monthly clinic meetings and discussed the plan with the staff and faculty, and developed instructions in an email that had screenshots of what it looked like and how to actually do it so that we could get that to our nursing staff. And then here it is. This appeared one day in clinic. It was like the aha moment. So this is what it looks like for us. It's under it's listed as other intake information, which is where tobacco, alcohol, recreational drugs, depression. Our PHQ-2 is a screen that we do for depression. And then at the bottom here, our physical activity scores. And this happens to be a very active coach of one of the schools I take care of. So she actually does meet national guidelines, which is nice. But that's what it looks like. So it's a tab. I look at it and I have that information without even asking. So what do we need? What are we still working on? There's a lot going on right now. We're marketing this, we're marketing PAVS, we're marketing the clinic consultations. We're developing resources. We've identified a couple of medical students that are helping us find regional resources. How do we adapt to cultural folks and the challenges they have in their communities? How do we find exercise programs? How do we use social media to help us? As much as I hate social media, I think it could help us. Can we get apps to use for our patients? We've written a manuscript surrounding our journey. We are developing templates to put in the EMR. And so we have a lot of EMR work still to do so that we can link the exercises medicine resources on the website into our EMR. And that's just starting. We have gotten a few patients here in the last few weeks, and peds oncology, surprisingly, were kind of the first people to refer. They're referring as children who had leukemia early on in life and received cardiotoxic drugs. And now they're adolescents and teenagers, and they want to know, is it safe for them to exercise? So that's been really cool population to work with. We have some grants in mind right now to help us develop this further, and in education, we're developing what that's going to look like and trying to offer what's called a physician navigator program for our medical students, where they can come and follow patients who are in this clinic. And we've already developed our fellowship curriculum surrounding this. Our fellows are going to be seeing these patients for consultation. So keys, timing was everything. You can't push this forward without the right people in place and having thought it out extensively. You got to have key stakeholders, which were in place, good mentorship, and you have to be patient with the process because you're going to hit roadblocks and you're not going to get meetings in the rooms that you want to be in, or they may be scheduled 3 months down the road. And you just can't move forward until you have that next meeting, and it may be months away. And finally, you can't do this alone. You have to be open-minded. You have to bring in all people in the health system that might be interested and might be interested in helping you move this along. That was it. You're muted, Mark.
I am muted. Wonderful. Thank you, Casey. That's a great intro. Remember, everyone, this is just to get us warmed up for the discussion. Casey, I see some questions in the chat box if you want to respond, but we'll circle back. Carrie, are you ready to go now?
Think so. I don't want to jinx myself, but let me give it a try here. Here we go. Is that showing up for you guys now?
Yes, it is.
Okay, perfect. Well, I'm actually glad that Casey went first, because I have a very different story to tell, and this is very helpful to kind of contrast everything. So let's just rock and roll here and get started. What I thought I would do is to give you a little bit of a brief overview of our health system and our department, so you kind of know the framework in which I'm working with this, and then I'll give you same thing Casey did, a brief timeline, and I'll get to the brief part in a minute. You won't believe me that it's brief, but it is. I'll show you kind of where we are with things right now, and then future work and things we're working towards. So our health system is big. We're ranked number 15 in the world, 11 in the country. We're number 1 in Michigan. We're huge, as you can see by some of the numbers here. So I won't go over them, but it kind of gives you a sense of our health system in general. Our department is very old. So we were one of the early family medicine departments in this country. We're currently ranked number 5 in the country. We have over 100 clinical faculty and APPs, 33 residents, 12 fellows just in our department. And in fiscal year 19, I thought I would go back to 19 given COVID and everything, but a little over 150,000 patient visits outpatient. So that's the framework in which I'm working. So this is what our health system uses. We use an Epic system. We customize it. So Epic is very popular throughout the country, but every health system has to have its own little tweaks. So ours is called My Chart. And this is what I see and what our medical assistants see when we see a patient. So you can see at the top, there's a rooming tab that's highlighted, and then you click on that rooming tab and it brings up all the things that our medical assistants would need to do to room a patient. One of those being exercise vitals, which you can also see is highlighted on the screenshot for you. And then these are the questions that are asked. It's simple, it's quick. The MAs just click 2 buttons. They're multiplied to give us a measure of minutes per week at a moderate or higher intensity of physical activity. And then in our EHR, what we can do is we have what's called a dot phrase. So it's a simple thing that you put in a template of your note, and automatically when I start a note on a patient, it automatically pulls in this information. So it's right there alongside a blood pressure and a heart rate and those sorts of things. I automatically get how many minutes a week the patient is exercising. But this is what it actually appears as to myself, medical assistants, nurses, so on and so forth. But the medical assistants are the ones doing this work and gathering this information for us currently. So here's my timeline. So like I said, when I started, this is the brief version of my timeline. I have the full version, which is multiple pages, but I started this back in 2015. And I'm not going to go over all this detail, but I just sort of wanted you to see that I spelled out many of the hurdles and roadblocks that I was encountering on this path, like Casey mentioned as well. Most of these roadblocks are with our electronic medical record or within my department itself. So I initially met with faculty in other departments that I thought should be interested in this, such as cardiology, medicine, pediatrics, med-peds, so on and so forth. And there was a little bit of interest. Many of their sort of representatives that stepped forth initially to embark on this were hesitant about many of the hurdles and roadblocks they would encounter. And so I sort of just decided to take this on initially within my own department first. I very early on started working with our IT system, seeing what I could do within my chart. And I actually made pretty impressive groundwork on that initially. So I got approval to start a pilot program for just me and my medical assistant and my patients. That's the only thing my department would agree to initially. So we started that pilot and it went well. So June of 2016, I asked if we could expand that to other family medicine sites. They said, well, you have to talk to quality improvement and present at this committee. Of course, like Casey was mentioning, meetings are scheduled a long ways out. So that got pushed out a long ways, and they felt after my pitch that there still was a lot of questions. They needed more information to decide if they wanted to make a decision. They said, you go gather all these other things that we want you to do, and then we'll schedule again a meeting much farther out. And then December 2016, I had twins, so that delayed everything. So I kind of got back on the bandwagon and started these efforts again in April 2018. They finally turned it on for all providers in family medicine, but only for health maintenance visits. So not for all visit types, but only for health maintenance visits. They got a lot of pushback from the health system to do it at all. And they said, we're not doing it for all departments. You know, you can kind of do what you want in family medicine, but we're not doing it in all departments. I did get approval to start one provider and MA pairing at each of our 5 clinic sites to do for patients over the age of 18. So that started in May of 2018, but I had to get approval from each of the clinic sites. So lots more meetings. So here's, again, all sorts of stuff, right? So kind of got this up off the ground, and then my screenshot that I showed you, that all changed. Like suddenly one day I was in clinic and the questions were moved to a completely different section of our MyChart system. So it was down in the social determinants of health, which at the time our medical assistants weren't even really touching that section. And when I went asked to get that moved back, they said, well, at a national level, we can't do that with Epic. And so I had to sort of partner with Cindy and Robin and Bob Salas and talk on a national scale to Epic leaders, and finally our health system let me push that through. And so this all just continued. And for sake of time, for sake of time, you know, I'll bring you down to the bottom here. In March, we had this up and running. March 15th was our up and running live date at all of our clinic sites for family medicine, all providers, all patients. So whether you came in for toe pain or a pap smear, you would be asked these questions. And unfortunately, 5 days after that, we got our first COVID case in Michigan, and the wheels fell off. We had clinics close. We went all virtual. It was a disaster. And so obviously exercise vitals fell off the radar of many. And so where I'm currently at is really trying to get the wheels going again. And so we've successfully, first of all, changed our wording from exercise to physical activity in our EMR, which is great. We did that to be more inclusive. And I was shocked to get that to be a go, but so that happened. And then really trying to optimize workflows for our medical assistants. We're doing, you know, a lot of video and phone visits in addition to in-person visits, and how do we incorporate these questions at all of those visit types. I'm again trying to re-partner with the other departments now that hopefully in a few more months we'll be fully up and running in our department, and I can say, hey, we're doing it well. Let's do it in your department as well. So hopefully partnering with more of the kind of primary care departments first, and then expanding from there. And then thinking about next steps. So I've made partnerships with community organizations such as YMCAs, other healthcare professionals. I'm our faculty advisor for our Exercises Medicine on Campus group. So we had this going at our student health system. As the director was a primary care sports doc, as Casey said, that's always helpful, but then he left and this was not continued. So trying to re-partner with them. Again, we have a new dietitian starting in some of the clinics. So a lot of, I think, positive things happening, but I'm hoping to learn from all of you. And so that's, you know, why I'm so happy to be here too, is to hear Casey's experience and Cindy's and hear the questions that many of you are raising, and hopefully we can spearhead this forward even more.
All right, wonderful. Thank you so much, Carrie. Let me help you get that off your screen.
I know, I don't know why I did it again. It wouldn't let me.
It's all you.
Great. Let me screen share here. Carrie's journey sounds a bit like mine too, with a lot of the Epic and EHR involvement early on, and then also having kids somewhere in between there too. So I can relate to that. So let me make this large. Okay, great. Hopefully you can see that. So I'm at University of Washington in Seattle, and how it all started. So actually Mark And I go way back because I met Mark when I was practicing medicine, sports medicine in Singapore. So after I finished my sports medicine fellowship in the US, I moved to Singapore and worked there in a big hospital. And it happened to be the site that is the exercise medicine Singapore lead and very active program there led by Dr. Ben Tan. Mark's been out there, Bob Silas has been out there, and that's how I got involved in the EIM group. So after a few years out there, we moved back to the States, University of Washington, and that's when I got really interested in launching this exercise vital sign program. And I also became involved in the EIM Emerging Leaders Program, which I encourage, you know, younger faculty or fellows to look into as well as an opportunity to get involved and get some mentorship. So basically how I started, and I think similar to the stories mentioned, is I found it really helpful to start small and say like, hey, this is something I want to pilot first, and to call it a quality improvement project helps a lot, because that's something that clinic leaders and clinics are used to doing, is quality improvement. And we're also required to do quality improvement. For instance, for my PM&R specialty board, I have to do a quality improvement project every 5 years and submit documentation of it. So that was an easy way to like get it in the door, is like, I'm gonna start small, it's just gonna be me and my MA, and then scale it to different sites. And just the Epic integration piece alone took about 6 months and a lot of different committee meetings to just figure out where to get it placed, because different committees, whether it's primary care or you know, there are just so many different committees for each department that control different parts of Epic. And so just depending on where you want to place it in the HR, know that that might be part of it. In terms of the healthcare system where I work right now, it's the largest integrated healthcare system in the greater Seattle, Washington state region, and also the #1 hospital system in Washington state. So we have a pretty big catchment. And this is how it looks like inside our Epic electronic health record. So for primary care, it actually goes under screening. We tried to get it in rooming under where heart rate, blood pressure, and temperature and oxygen is. But then the debate sort of within that committee, well, they're like, well, physical activity is not objective. And well, pain's that, you know, and then so we had this whole discussion because pain vital is under rooming vital sign. I'm like, well, pain's not objective. Why is pain there? And physical activity is also a self-report. But anyway, so where it ended up, sometimes you got to compromise, is screening. And so the MA, when they're rooming the patient, they'll fill out the blood pressure, heart rate, and then they go to screening and they click on these questions, which, you know, I took them at that time from how Kaiser has it in their healthcare system. So that's why it's called exercise vital sign instead of physical activity vital sign. We did make one wording change during this, once we started integrating this in clinics with patients with disabilities. So we changed the wording from like a brisk walk to just breathing harder than normal. The reason being that we started it in an amputee clinic and now we have it in a multiple sclerosis clinic too. You know, saying, you know, having an MA read something that says like a brisk walk to somebody who just had a limb loss just wasn't appropriate. And so we wanted to be more inclusive. And so that was one idea, and it's been very well accepted by the patients and the staff in the rehabilitation clinics. Let's take a look here. Okay, so this is what it looks like in our clinics. So actually one of the MAs came up with this sign, and I mean, I came up with the sign, but she thought about putting it on the vital sign cart. So basically prompting again the medical assistant when they're taking the patient's blood pressure and heart rate, ask exercise vital sign every patient, every visit. And that was one of the big barriers when we started, was that, you know, we would get medical assistants coming up to us, whether it was sports medicine clinic or primary care clinic, saying like, well, who should I be asking this to? Like, should I not ask the people who are pregnant, or should I not ask the patients who come to us in a wheelchair? And that was a really important discussion, because we really believe that everybody can move and find ways of moving, and that we should be asking everybody, whether or not they're pregnant or they're presenting in chronic pain or they just had surgery, to just really make it something, ask everybody. And that helped to simplify it, because the MAs then didn't feel like they had to decide who they should be asking or not. So it's really important to get their buy-in, and you know, the clinic manager, trying to reassuring them that it's not going to take more time. So in our primary care pilot, we actually started it on a little slip of paper passed out with their intake sheet, or I know in one clinic we started it on paper on their intake sheet because the MAs were really concerned it was going to slow down their rooming. But then once they realized it barely took any time, and actually that most patients who say they have 0 minutes of exercise, it takes like less than a second, that they were like, oh, it's fine, I'll just ask the question. Like it doesn't take actually that much time. You know, a lot of MA questions early on, like what counts as physical activity, because patients would be like, well, does it count that I walked from my car? And then they get into this whole discussion. So, you know, these are the kinds of things you may encounter. So just bringing it up to where we are today. So about almost, I think, 100,000 patient encounters have had an exercise vital sign within our healthcare system. These are all the different clinics where we have ongoing research. And so this is something I really recommend, because I mean, it's something I feel like, you know, an individual, you can pilot it yourself with your MA, you can do it as a quality improvement project, you know, hopefully even get credit for your board, your specialty or primary care board. And but then once you want to expand it to other clinics, it's great to find a champion in each clinic, or even a resident or fellow who's just super excited about and passionate about exercise too, and they can do it as like a small project. So that's what we did this past year, 2020, in a multiple sclerosis clinic, is that we had one of our resident physicians and one of the MS physicians just spearhead it, and they were able to assess about 1,000 patients and submitted a conference abstract for ACSM. Again, primary care clinic, we had 2 primary care resident physicians lead that and have presented research at conferences and have won some research awards. Our rehabilitation medicine rollout, we had a publication, one of our residents who's now sports medicine fellow at Utah, he helped with that. And so really a great way in our system has been to find a faculty member in that clinic, and then a trainee who's just really enthusiastic about it. Because once we kind of had the framework down in one clinic, which was sports medicine, it was just so easy to roll out in these other clinics, because once the other clinics see there's a precedent, they're like, oh, okay, this is how you find it in Epic, and this is how you do it. And so this is some of our research, I think, out of primary care. So we found that about 1/4 of the primary care patients reported 0 minutes of exercise per week. And right now we're doing some utilization research and also research on disparities based on racial ethnic background, because there are some differences in self-reported exercise based on people's backgrounds. And this is our publication, Physical Activity in Adults with Amputation as Assessed with a Self-Reported Exercise Vital Sign. And you know, some of our key findings were that those who have a limb prosthesis are exercising more than those who don't, for the lower limb amputees, and then female patients tend to report less exercise than male patients. So in terms of where we're going now, we're continuing to expand it to other clinic sites and in primary care. Yes, certainly doing a lot of things by telemedicine does throw it off in this COVID world too. So, but we're, you know, trying to work with it, and some of our clinics are still asking the exercise vital sign even on telemedicine, having the MAs do that when they can. We are looking at some mental health, looking at relationship between PHQ-9 and GAD-7 scores that were already previously collected within Epic for primary care. Looking at some healthcare utilization, you know, are there differences in people who self-report less exercise, and how often they use emergency room or inpatient hospitalizations? And Liz Joy's team has given us some helpful feedback on that. And I'm also working on a project with computer science on campus, where this is just a really simple step count app, but it's going to be integrated with Epic. And basically just something simple, we can just give patients a QR code, and then it'll just help support them in really small step count goals. So it's not going to be like 10,000 steps a day. It's going to be more like 4,000, 5,000 steps a day for our patients who face a lot of activity barriers, and then try to solve some of their specific personal barriers and facilitators. So that's basically where we're taking it, but it's been a long road, a lot of years, a lot of great support from, you know, Bob Salas, Liz Joy, Mark, Robin, from EIM, and learning from others too along the way. Thanks so much.
Wonderful. Thank you all so much. That's really a great overview of your presentation. So a number of comments, and let me scroll up and we had one from Robin and another gentleman really just bringing this back to the research aspect. And that's what we're at here with this RLC. And so I'll throw this out to the panelists really is like, what is your vision? And I think Cindy, you got into it a little bit more, but where are you thinking of taking this for research? And maybe it's nowhere, maybe as practitioners, your primary goal is making sure you do the physical activity vital sign, but really, if you are looking at it from a research perspective, where are you hoping to take things? So Casey, you mentioned that you're starting to set up the infrastructure. What's your thoughts in the future is turning this into research opportunities?
That's moving forward quicker than we had anticipated. So it's a lot of work to get PAVS up and running just in itself. And so we've just gotten there. So I look at the work that Cindy's done and I'm like, wow, you know, that's where I want to be, where we have 100,000 patients that have been assessed, and we can start to really look at these patient populations and understand how we can best implement exercise and be successul. But one of the, I think, I honestly felt it would be a long time before we would be ready to do this, just as the pieces are continuing to come together. But we're fortunate to have Katie Smits here at Penn State, and her life is research, and you know, her areas, particularly in particular cancer and exercise. But you know, she's approached us with some ideas on how we could potentially roll out physician education models using PAVS and kind of a hub model, whereas you know, at larger medical center, we can reach out to rural areas, whether it be via telehealth or well, mostly via telehealth, to teach providers not only locally, but regionally, how to do this. And basically just using the guidance that EIM has already provided, just with your SBIRT, just screening, brief intervention, and referral to treatment, we know is effective. There's data on that already. And just having PAVS, we know is effective in increasing the amount of physical activity that a patient will do, just asking the question. So, you know, I think reaching for the lower fruit will help us with broader implementation. And, you know, if we have data that says if we just ask the question, people will be more likely to exercise, then I think that's where we're going to start. And our first research initiative here is going to be looking at how do we get other providers in our community and regionally to just start asking the question.
Excellent. Good. Carrie, we'll turn to you. Same question. What type of faculty are you reaching out to, if any? What are your future research thoughts? Where do you see yourself going with this as you start to roll it back out after COVID?
I think it's a great question. I think my role may be a little bit unique in that I am a clinician and an administrator. I don't have any research time allotted to me. So actually all of the work I'm sharing with you today is all in my free or personal time that I've done. And right now I'm at least in a very practical world, meaning that I am trying to get this pushed out to as many places as I can to reach as many patients as I can. But part of that, my sort of next step goal is better partnerships with community organizations, which I've made some fantastic connections. And so we're hoping to use that as a kind of research stepping point to look at primarily like mental health outcomes with kids and teens in particular, if we can get them to be active and participate in some of the programs that we're developing. So I am in the extreme early stages of that piece of things. But again, right now I'm sort of in the practical world of things.
Well, and you know, Carrie, one of the things Robin and I have talked about is that we have this world where there are the clinicians doing really great things, but we're not getting that evidence out there because, like you said, you're 100% for clinical. And then we have a lot of people on this call and in this RLC that are researchers. And we're saying, how can we connect those people? So maybe that's something in the future that we can help connect you to some people who'd be interested in helping you mine data to show that what you're doing is working really well.
Yeah, absolutely. And I should say there's certainly interest in physical activity through our kinesiology department and others, but of course there are competing interests. And everybody has so much on their plates right now. I've made great connections in that regard, but nobody has sort of the bandwidth to take anything else on, unfortunately, right now. But hopefully, yes, we can make some connections and learn from each other today.
Absolutely. Wonderful. Thank you. Cindy, do you want to add anything that maybe you didn't cover in terms of your future plans for research and the type of people? It sounds like you're pulling in people from all across campus to help you with this. Anything else you'd like to share?
Yes, I think when I talk to, we've talked to our CMO and hospital leadership about this. I mean, they care the most about what's the impact of it. And so I think that's hopefully where we're going with our research, which is they want to know. I mean, we could show that asking patients about physical activity, identifying, we could risk stratify patients in our healthcare system, meaning that, wow, patients who self-report that they don't exercise, they actually end up costing our healthcare system more. Then I think, people will start paying attention. And so I think that's the powerful nature. I mean, those kinds of studies would be really meaningful. And I think like, even my group, we're trying to figure it out as we go. So if there's like people out there interested in that sort of like healthcare outcomes utilization, as we move towards value-based medicine in our system, that'll really position exercise well in the future and the value that exercise professionals will play in making a difference in those patient populations. And I think secondly, in terms of, I saw some questions in the chat too. I mean, that was exactly a question. Like we'll ask the exercise vital sign and then the primary care doctor is like, well, then what do we do with it, right? Like, what's the next step? Like, who are the people in the community to refer to? And now it's even harder with COVID. So, we've had to think about, okay, what are home-based solutions? Are there ways of connecting patients to EAM certified exercise or ACSM certified exercise professionals, over Zoom or, at home? And so those are some of the questions in my mind too, about how can we how can we really meet the needs of population moving forward in our new world of telemedicine? Yeah. Oh, yes. And Robin just put in a really good message. Yeah, the prescription for health series. That's super helpful to have in the clinics.
Well, and Daniela asked a question really talking about implementation science and has that been looked at? And Cindy, I think you kind of addressed in what you just said is that what's the next step? But everything we're talking about when you all are talking about PAVS, that's something that's in the EHR that's being recorded. Now all of a sudden, all these encounters that are outside of the EHR, how are we tracking that? How do you track Carrie if they go to a community program, or Casey if they're connecting with something in the community? Cindy, I love your idea with the app because at least maybe that, if that's integrated, can track back in. But this is the core of evaluation. I don't know if any of you have thoughts to that.
I can share some things that we've sort of brainstormed. So what we're working on right now is the physicians would actually place a referral in our EMR, and that would go to the community agency I'm working with. They would have the ability to, right now we're thinking fax back an evaluation form that we can quickly scan into our medical chart, and then it will be routed to the patient's primary care provider so they can get that feedback fairly quickly. We're trying to make that even more smooth, where they can have access to our MyChart system just to submit information. They wouldn't be able to gather information, but just to submit, because that's far easier to gain access in that way. So we're looking at that as an option too.
Casey, you mentioned, yeah, go ahead, Casey.
Well, I was just going to say, so your question, are you speaking of how do you understand what's happening in the community if they're not doing the vital sign in their system, or they're not in your EMR? Is that where?
Yeah, sure. I was talking more to the sense that, like, there's been these questions about, well, what's the next step? You do the PAVS and people are inactive. And so Cindy and Carrie and you're talking about, referring these patients out. How do you track that, from a research perspective, to see if they're actually going, to see if they're doing it, how do you measure that as well to see if you're having any effect in providing these referrals after the assessment?
Well, and so we're very early in this, but our initial plan, on a small scale, at least a pilot, being able to follow these patients is it's going to be an elective, basically. It's a required elective for our medical students. It's called a Physician Navigator Program, and we're going to get, based on volume of patients, we're going to be able to pull medical students in. They will contact the patients and they're going to follow them and see if they follow through with the plan. And we know that there's data to support that. The more touch points, the better. And so we're trying to pull in any resources we can to continue to call, ask them, were you able to do this? Were you able to do that? Once we've identified, the resources that are available to them. I would like to, on a smaller level, so everything in our health system is about justifying the financial plan. And I have to validate while we're doing something. And so it's going to take data to do that. And initially, from a physician-based perspective, I need to be able to show that I need people to do the touch points. I need staff to be able to call the patients and follow through, make sure that they're doing it, because we know that that's most effective. But to get, it's just kind of like piloting the PAVS. Like I'm not gonna convince anybody that they need to hire anyone to help us with this initiative unless we have some data that shows that it's an effective way to go about it. And we just don't have that yet. And we have very little data on PAVS implementation, which was why one of the reasons we're all talking about this and sharing ideas. It's just so new from a health system perspective. Anyone who's been engaged with exercise as medicine since its inception, like owns it. Like they know that this is important. It's a no-brainer. But to the general population and to the general physician population, they haven't heard of exercise as medicine. And I think we have to figure that out. And this is just the beginning of it. We have to figure out all these little projects that we're doing in our health systems are going to start to provide smaller amounts of data that we can use to validate why we need to continue this and increase resources in this area, which ultimately, again, from the financial perspective in our health system is going to be saving them a lot of money because patients are healthier. From my perspective, my patients are healthier. That's why we want to do this. So.
Great. Let me package a couple of questions together. I'll throw this at you first, Cindy. Peter earlier asked what's your metrics of success with the PAVS itself? Can you talk to the percent of patient encounters this is being asked at? What are you aiming for? How are you trying to change that? And then our recent question was, then looking at that, how do you think it's impacted from provider to provider based on their own personal knowledge or health habits?
Great. So for the first question, in terms of uptake and adherence of continuing the exercise vital sign, it's varied clinic to clinic, depending on the provider. So if, it was kind of like if we had a research study going on, it definitely was more motivating for those providers to continue doing it. And if there's a lot of MA turnover, staff turnover, that definitely led to drop off because then you have to retrain them, but we may not know about the MA turnover. I think last year there was one clinic that had a major flooding event and then they had to stop doing the exercise vital sign. It was just like there's too much going on in that building. And so there's like so many variables that contribute to that. Sorry, what was the second part of the question?
And how do you think that's impacted at the provider level by their own personal habits?
That's interesting. Right.
Yeah.
Yeah. So, You know, it's really interesting. So I think the clinics where it was more successful with the rollout and there's better adherence are ones where the nurse manager or the clinic manager was a part of that initial meeting, where we just kind of had a 10-minute meeting over lunchtime and we're like, we're going to do this, we're going to start it. Like, this is how we do it in the other clinics. Any questions? And then the nurse manager was there saying, like, everybody's going to do this, every patient, every visit. And then I think one of those clinics, it was like really high, and they still to this day do it. Whereas other clinics where it was more of an ad hoc, like I started it and then I asked the guy next door, the other physician next door, for him to start it. And then another physician in a different pod started it. Like, that just didn't really work as well. So I think if you can bring a clinic together and decide to make it a quality improvement change, you'll have a better sustainability of it. And I think definitely physicians who exercise regularly seem to have greater buy-in. I've had other physicians just say, like, exercise causes pain, or like, I'm not sure how it would be helping my patients. And so kind of, you know, finding champions who believe in exercise themselves is a good starting point.
And Carrie, we'll shift that question to you. Is you know, what, as you roll this out, what is your goal for success metrics in terms of getting people to do this, and how do you think it's impacted by physicians and MAs and nurses and their own personal habits and beliefs?
Yeah, I think, you know, my end point, again, I'm so early in this that right now my end point is just to get it rolled out. My ultimate goal is every patient, every visit in our entire health system. I stepped into a role as medical director of our largest family medicine clinic. And so at my clinic, we're doing great, right? Because I'm medical director and I just say, this is what we're doing and that's how it is. But like Cindy said, you know, the uptake in other clinics, it's variable right now. And you know, when I initially presented it to our faculty meeting, you know, my thought was that, well, first of all, if I'm going to ask people to assess physical activity, then I probably should educate the providers on what the recommendations are and so on and so forth. So when I gave that talk, I will share that I got a lot of backlash from some of my colleagues, a lot of backlash in terms of, you know, we're just bombarded with so many competing interests, right? We have these best practice advisories, and these are these quality metrics, right, that we need to meet. A diabetic foot exam, is your patient on a statin? I mean, the list goes on. And people, I think, just sometimes feel overwhelmed by that, but I just have to kind of redirect and say, this is the reason for it, because it actually makes a difference and we can show that. So my ultimate endpoint, I would love to get this rolling across the health system and then look back and compare costs. Is you know, it all comes down to money. And so can we look at costs or hospital admissions or some other metric? I don't know what that is yet, but that's sort of my thinking. And then in terms of, you know, providers' own habits, at the flip side to that presentation that I gave to our faculty, I got a number of faculty that kind of snuck up to me afterwards. They were like, I had no idea that these were the recommendations. Like, I'm not anywhere near that. You just sort of inspired me to start this own process. And I'll also share, I just saw one of our former residents who's at a different clinic that I don't see that often. I just saw her recently and she's lost a significant amount of weight and just looks fantastic. And I hardly recognized her. And I actually pulled her aside and I said, hey, you know, what's going on? I hardly recognized you. And she said, to be completely honest, it all started with that talk you gave us. I wasn't doing any of that. And that just kind of sparked all these healthy behaviors for her. And so, you know, things like that are amazing to hear. So I'm hopeful that not only will this spark our patients to be healthier, but also our staff, our faculty, all of us. You know, this isn't just for our patients, this is for everybody.
Fantastic. Thank you, Carrie. So we have 5 minutes left here. Maybe we'll finish with a minute from each of you, kind of summarizing some of your thoughts. And really, like, you know, being a research learning collaborative, what advice could you give, Casey? I'll start with you here, to the folks on this call and that will be listening to this call about how they could connect with people like you at their health systems, or things you think they should be thinking about in terms of advancing this research field.
I think Carrie's point about clinicians and not having research time is really a great point. We don't have time to do hypothesis-driven research. Most clinicians don't. And in particular, health systems are struggling right now because of COVID financially, and in our health system, we lost a lot of time that we might have had for academic endeavors. And so it's just really hard. And not only that, we're clinicians. We weren't trained in doing good, well-done, hypothesis-driven research. And yes, we read it all the time, and some are better than others, but partnering with trained individuals who know how to do good research, I think would be my advice. We shouldn't silo ourselves. We didn't silo ourselves when we implemented the PAVS. It took a group of people in a lot of different areas and who do a lot of different things to actually get this into the health system. And I think research should be the same. Multidisciplinary. We should use each other's strengths to develop meaningful hypothesis-driven research that will move this forward.
Fantastic, great advice. Cindy, any final words of wisdom to share with both clinicians and non-clinicians, right? There's a lot of people on this call that are excited to partner with clinicians to get involved. What words would you share with them?
Yes, I think that collaboration is so important. As it's been echoed, like clinicians, we just don't have the bandwidth or the time to do this type of research, nor the expertise. And so I think if there's a way we could kind of build an understanding of, what research interests people have, then we can better connect clinicians to those researchers so we can really start developing under some of these key research aims that will help advance EIM forward and really show healthcare systems the value of doing exercise as a vital sign, and how, if it's going to save them costs or if it's actually going to improve their population health outcomes. So yeah, I think there's tremendous potential and brain power on this call. So
fantastic, thank you. Carrie, you have the last word. Any words of advice for everyone trying to get involved with research in this area?
I echo what Casey and Cindy have said. I think breaking down our silos is where I spend so much of my time, and have been successful in many regards, but not as successful as I would like to be. And I think the other thing too is that it's exceptionally hard for clinicians to sort of branch outside of our own health systems. Hard enough to collaborate with a researcher in our own health system, but to partner with other clinicians in other health systems, or certainly other researchers, as well, as something I would love to partake in, but it's definitely a challenge. And I will just add at the very end that one of the biggest hurdles that I'm seeing with all of this is support for that next step, right? Insurance companies do not want to support us referring out to community organizations for the most part. And that's a huge hurdle for many of my patients. So I think that would be another sort of area to all of this where some of the research or ideas could focus as well.
Thank you, Carrie. Thank you, Casey. And thank you, Cindy. I think this has been just an absolutely phenomenal recording. Anyone who wants to view it again, we'll have it up on our website by next week. And we'll be planning a next event to follow up on this. But the three of you, thank you so much. And thank you for everyone for joining us today. And with that, I think we'll conclude today's panel discussion.
Thank you for the invitation, Mark.
Appreciate it.